All right. Welcome everyone to another shadowing session at Hearts for Health. We're really excited to see you all today. I know this is the middle of final season for many of you, so best of luck with finals if you're currently in that period for our students out there. And to those on their gap year, if you're getting ready to apply, good luck with MCATs coming up. I'm sure MCATs, DCATs, a lot of you taking different exams. But I did want to quickly kind of open it up with some reminders before we get started. We're joined today by Dr. Shah. He's a pediatric dentist, and he'll be talking a little more about himself as we go on. But just some reminders, especially if you're new to virtual shadowing, just want to familiarize you with our typical format. So at the end of each of these sessions, we have a Q&A, and that Q&A is pulled from questions we have in the chat. So that chat is either to the right or left, or sorry, the right or the bottom of the video that you're watching right now. And in order to ask those questions, just type them in the chat and we'll read them. Once we roll around to the Q&A, we'll go through them in the order that we received them. So at any point in time, feel free to type in your questions in the chat. Also, for those who want to stay updated with future shadowing sessions, because we do have shadowing sessions typically every bi-weekly, so twice a week, typically on a Monday, Thursday schedule, but there are some days that we might have it outside of that. And just to keep in the loop, you can either follow us on Instagram or join us on our email listserv. Our email listserv is something that you can join manually just by emailing us at shadowing.h, the letter 4, or the number 4h@gmail.com. Or you can go onto our website, scroll all the way to the bottom, and you will see our subscription form. So fill out that subscription form and you'll be ready to go. Outside of that, if you have any questions for us, feel free to shoot us an email, but I will be talking a little more about the quiz at the very end of this session. So if you have any questions as to how you can earn credit, I will be discussing that at the very end of this presentation here. So with that said, Dr. Shah, feel free to take it away.
Good evening, Michael. Thank you for having me in this platform. And then for those of you who guys are at finals, thank you for taking the time out on a Wednesday to join and joining, I guess, from the YouTube link. This is a little different for me because I'm used to talking to an audience, and I know you guys are like kind of, joining in virtually. I love questions. There's no such thing as a stupid question. Dentistry is a little bit different. It's almost like a very different side of medicine, so to speak, that doesn't get talked about as much at times, especially when it comes to pediatric dentistry, which I'll be talking about today. So more questions the merrier, and whatever I can do to help you along the way, dental related or non-dental related, feel free. But let's see, is my screen being shared with you guys?
It's great. If you could put in full presentation mode. Right now, we just see the full slide deck.
Yep, I will do that right now. Let's see. Should be good to go. All right, so welcome guys again. Welcome to the world of pediatric dentistry. So my name is Dr Shah. I am a board certified pediatric dentist. Have some of my information down there. I also see a lot of special needs patients as well. In terms of what I do, I'll be doing a little bit of a deeper dive into that, but I'm Chief Dental Officer for an up-and-coming DSO, which is like a dental support organization. Organization's called Oak Dental Partners. And then I also teach part-time at the University of Pennsylvania School of Dental Medicine and CHOP, which is Children's Hospital in Philadelphia. And so they're working with the residents, which has been awesome. So academia has been super rewarding as well. So a combination of private practice and kind of like the private equity sector as well, so business aspect of things, and then also in academia. So almost like a three-headed monster, which has been kind of neat and super rewarding. In terms of a little bit about me, so I'm a husband, a father of 2 boys, and I'm a fur daddy. So I got a golden doodle who's our first kid. He's 6 now. I've got 2 boys, Aryan and Rian, who are 5 and 3 respectively. And then my wife, Wani, who closing in on our 10-year anniversary next June. So really, really grateful for my family. It's the first and foremost. I love sports, avid tennis player, pretty much anything, football, basketball, skiing. I love to travel the world, and then I just love reading. So whether it's book, podcasts, Audible has been kind of a new thing for me on the road since I travel so much. So if you have any, want any recs on any books out there, feel free to reach out. A fun fact. So I think the majority of you guys are pre-med, pre-dental students, or in college. And so when I was in college, I danced competitively throughout undergrad and in dental school. And the cool fact was I was actually asked to dance in Bollywood, which is like kind of the Indian version of Hollywood. For those of you who are not familiar with it, was so close to going, it just would have taken away my entire second year of dental school. And no pun intended, but I like skimmed just by the skin of my teeth, got through second year of dental school. It was tough, and I did not want to retake that all over again. So gave it up, did not decide to go forward with it. But looking back at it, I figured if it was meant to be, it would be meant to be, and I'm really happy with where I am now. In terms of a little bit about my professional life, I am in private practice, which is in Exton, Pennsylvania. If any of you guys are familiar with King of Prussia, it just kind of became the largest mall in the U.S., overtaking Mall of America, maybe about like 20 minutes west of there, so in the suburbs of PA. And then in the private practice kind of arena, it's a balance between seeing my own patients in the clinical setting and then my chief dental officer responsibilities, which entails me traveling every other week. And I get to travel to different states. I'm currently actually in Tampa, Florida, as we speak right now, doing some mentorship and working with our doctors down here. So that's a really kind of neat and rewarding role that has taken on a significant meaning for me. In terms of academia, I'm an attending at Penn Dental. And so residents there, I run their oral conscious sedation program. Then I also help with soft tissue laser. So using the laser to do frenectomies, any other type of exposures, teeth exposure. Some of my cases will touch base on this a little bit as well. So you kind of get a little bit of a better idea in terms of what I'm speaking about in that regard. My undergrad, I went to Drexel in Philadelphia. I did a majored in biology with a minor in business administration. And then for grad school, dental school, I went to the University of Pennsylvania, graduated in 2013. I went right into residency at the Children's Hospital of Pittsburgh at UPMC, Pittsburgh, Pennsylvania. Got out in 2015 from residency, and then kind of, been practicing since there. Different offices. I've kind of gone through different stints. Joined a family practice up in Scranton, home of The Office, if you guys are familiar with that show. Was there for about 2.5 years, wanted to be closer to family, moved down to Philadelphia, joined another group that, wasn't too thrilled with. Life teaches you a lot of lessons, and then ended up joining the office that I'm currently with after having much thought and thinking about opening my own practice. But I found a great opportunity here, and I've been with these guys since 2019, which is the same year I went to academia, and the rest is history. So at the end of life for me, in terms of private practice, I start at 7:30. I'm done by 3:30. In the mornings, I start off every morning with an oral sedation case. And what that is I break down oral conscious sedation. Oral meaning I'm giving a child medication that they're drinking by mouth. Conscious meaning that these kids are awake. They are in twilight and they're a little bit out of it, so to speak, but they are sedated. So that's kind of OCS, oral conscious sedation, kind of breakdown of that. I do these to help kids who are maybe a little bit more anxious, have a little more dental needs, and going the conventional approach of laying back on the chair with or without laughing gas on the nose, if that's not enough. And maybe taking them to the hospital setting or working with an anesthesiologist in the office and having these kids completely asleep under general anesthesia is overkill. And so this is a nice happy medium that I'm able to do for a lot of our guests, patients, so that way they're able to be treated. Dentistry, especially with what I do, see a full array of treatment. We're talking your basic, bread and butter fillings, which is what, when you hear the dentist, it's kind of what you think about. We do a lot of crowns. So, stainless steel crowns is kind of standard of care. There's a lot of zirconia. We're kind of living through a very kind of aesthetic and a kind of time frame, so to speak. People want, aesthetics and quality. And so there's a lot of great options now in dentistry that weren't available in the past. One of them being zirconia crowns for the front and back. So I do a lot of aesthetic dentistry, your basic extractions, the use of laser, and then, like I said, some of these sedations, whether it's oral conscious or have the anesthesiologist and have these kids fully asleep in the office. I run one column of operative, and that's like, physically doing the treatment that I just alluded to, about 10 to 15 of those patients a day, and then 3 columns of hygiene. And so these kids are coming in for just having their teeth cleaned. Some of them, get x-rays and, diagnosing if there are cavities on the x-rays, talking to their parents. So, see about roughly 45 to 50 of those guests. So all in all, I'm probably looking at about like 55 to 60 patients I see a day. Got a great team, a great supporting staff. So it's, makes it super, super smooth and very easy to do. Heavy sedations where these kids are fully asleep. I do that every 3 to 4 weeks. And then in terms of my clinical, mentorship or clinical director role, I'm on the road, like I said, providing mentorship and overseeing some of the clinical and compliance operations of our offices. With academia, I'm there, like I said, on Fridays. It's usually actually from 7 to 1 o'clock now. I help run that sedation program with the residents and making sure these residents are getting exposure and are able to take what they're learning and now apply it, in the next year or two as they come out of residency. We have seminars, sometimes in the morning, sometimes in the afternoons. And like I said, I will work with sometimes the dental students, but it's predominantly the residents. So let's jump into a little bit of baby teeth. Let's take baby steps to understand pediatric dentistry, and when you hear pediatric, you think of baby and the infant toddler kind of stage. So some fun facts in regards to the primary dentition. You'll kind of see a graph right there in front of you. There's 20 baby teeth in the mouth, and the cool thing here is that they're identified by letters instead of numbers. The adult teeth are numbered 1 through 32. Most of you might have 28. And that's because the wisdom teeth, end up coming out. The 4 wisdom teeth. Some of you guys may not have all 4, may have had 3 removed or 2. Some of you may have been lucky and had 0. I wish I was as lucky as you were if that's the case. But when it comes to baby teeth, there are 20 of them. All 20 of these will exfoliate, meaning they come out and they get replaced with adult teeth. The only ones that don't come out are the molars, the 6-year-old molars, the 12-year-old molars, and then if you're fortunate to have those wisdom teeth, those molars, those 3 sets of molars are the only teeth in the body that don't lose a tooth. They just kind of automatically come in as your jaw, upper and lower jaw, goes through growth and development. So a lot of people hear baby teeth and they're gonna, you're gonna lose them. Why are they so important? But they play a super, super, super critical role in terms of growth and development, in terms of functionality, chewing and eating and drinking. You don't lose those back, baby teeth in the back, your back molars till you're about 11, 12 years old. The bottom 4, the top 4, you lose around the age of 7, give or take, like I said, 6 months to a year here and there. And then those back teeth take a little bit of time here and there. So there's a wide range of them. There's no, such thing as one. It depends on, your growth and development. But with that being said, these baby teeth lay the foundation for the adult teeth. And just because you lose a baby tooth doesn't mean the adult tooth comes in right away. So you want to salvage them, protect them in terms of, functionality, in terms of spacing. So if you can keep all your baby teeth and you don't prematurely lose one, and you're not worried about teeth kind of moving in. Teeth are super selfish. They grow in the bone. So if there's a tooth that's missing in front of a tooth, that tooth is going to want to tilt and kind of take over that spot. Long term, orthodontics. And so if you had braces, a lot of people think about braces in terms of, hey, let me make my teeth, straight and aesthetically, pleasing to the eye, which is great. But if we can catch at the right time and we don't have to worry about tilting up certain teeth and making that orthodontic procedure a little bit more extreme, then, keeping all those baby teeth will play a huge role in that. So with all of this just being said, I have there on the yellow, it's important. Oral health and dentistry is more than just teeth. And I hope this presentation kind of hammers that point home. It's comprised of, yes, your hard tissue, which is your teeth, your soft tissue from your tongue to all the mucosa that you have in your mouth. And like I said, one of the biggest thing, that tongue, which plays a huge role in your overall health. So these 3 components, the hard tissue, the soft tissue, and tongue, kind of culminate and come together to create a vital role in your oral health. So what is this pediatric, what does my profession entail? So, it's a combination of oral health and facial growth and development from infancy to teenagers. Now, being pediatric, I do have some patients who are special needs. I've got a couple in their 20s. I have one who's actually in his 30s, early 30s, special needs and cardiac. For some of those exceptions, I will see these kids lifelong, or as long as their parents, want to be seen by myself or another provider. We like to have kids in by, I call it the rule of 1. So whether before the child turns 1 on their first birthday or when their first tooth comes in, whichever comes first, and that's what I mean by the rule of 1. Why is it so important to get these kids in at that, within that time frame, follow that rule of 1? Well, 2 big things. One, we want to establish a dental home. So a place where we get to see this child and make sure that their growth and development is appropriate for their age. The next big thing is, obviously, when you're little, you're not making health choices. You're not going to the grocery store as a 6-month-old. You won't be crawling, but you're not crawling down the aisles and picking up food and putting it in the cart. So you have to rely on your parents for that. And so the goal here is to let these parents know, how can we help optimize your life and your child's life through healthy choices, especially when it comes to diet and home care. And so anticipatory guidance means just helping these parents understand what to expect in their child's growth and development and their oral health in the months, weeks, months, years to come. And so those two big reasons are, kind of the niche and the foundation of, having these kids come in early. And there's a variety of dental needs that pediatric dentistry encompasses. Cleanings, you have x-rays, your fluoride treatment, you have these white fillings, which are called resins or composites, amalgams, which are being done less frequently, but those are the silver fillings that they used to use back in the day. You've got some nerve treatment or pulp therapy. SSC stands for stainless steel crowns, zirconia crowns, like I alluded to earlier, your extractions, your sealants, spacers, interceptive ortho to get certain kids earlier. And then frenectomies, which is releasing tissue. It could be, impeding the upper lip and, having it attached kind of at that mucosa, or many people are familiar with the tongue tie. And so that entails, releasing that part of the soft tissue where the tongue is connected to allow functional optimization of the tongue. I will dive deeper into that as a study case as well. So, and then along the way, these are kids. So, you have to have a lot of different treatment modalities to kind of get through your treatment, whether it's behavior management, talking about princesses, superheroes, kind of whatever fits the mold, Disney characters. We use nitrous oxide as a medication, which is also known as laughing gas, to help with anxiety. Oral conscious sedation, having some medications that the child drinks in a conscious state, but allows them to really help them with their anxiety, and has some of these medications may have a little bit of amnesia effect. So it makes it a lot more of a positive experience. And then you have your IV sedations or your general anesthesia, where these kids are completely asleep, whether it's in the in-office setting or in a hospital or at a surgery center. So the experience of how you deliver care is the key, right? I mean, I think we're living in a day and age right now where if you went to Dr. A and Dr. B, and this is, I think you can apply this to anything, not just dentistry, you're not going to compare, well, I'm going to go to Dr. A because I expect his work to be better than Dr. B or Dr. C. You want to have the work. We're living in a day and age where the quality of the work has to be here. It has to meet a certain standard. What's different, however, is the experience that a care is driven by. And so what I mean by that is, in a pediatric office, do you have a TV in your room? Do not have a TV. Is a TV in direct access so the child's able to easily look at that TV while they're laying back? Or are they constantly getting up because your TV's in the corner of the room? So these are small things. I almost call it interior designing of an office, to make sure that you're optimizing the guest experience or the patient experience. All of us, whether you're live on this right now or you go back and listen to this at some point, you have insecurities and you have traumas. We all do. This kind of shapes us into who we are today. And if you really think about your insecurities and traumas, a lot of them stem from our childhood. And so what is one thing that I think every provider who works with kids is trying to do is, how do we decrease that white coat syndrome? How do we minimize insecurities and traumas in kids? And I call it the T word. Trust is huge. So how do we gain trust in kids? I think that's one of the coolest things with pediatric providers, that you're kind of on your toes, and you're trying to make this experience as positive as possible for them. And throughout the process, you're never, ever, ever want to compromise ethics and integrity. And so that's the biggest thing. So I love to tell my residents this, and as you guys are going through, your career choices and your lifestyle choices, whether it's med school, the different, disciplines of medicine, or different disciplines of healthcare. Could be, pharmacy, could be dentistry, could be what's called optometry, ophthalmology. Just keep these 3 A's in mind. It's something that I feel like does not discriminate regardless of your profession. Affability, availability, ability. Sadly, we're all judged, and I think as a world we're coming, I think less trying to judge people less, especially with mental health coming at the forefront. But your patients will quote unquote judge you based off of these 3 A's and in that particular order. Are you affable? Are you likable? Can you have a smile and a warmth to you? That's the first thing people are going to want to see. Like, I jive with this doctor. My kid, wow, like they really like this environment. So are you affable? Is your environment very friendly and open? Are you available? You could be a phenomenal provider. If your wait time is like 6 months or 8 times, Dr. Shah, listen, man, I think we really like you. Little Johnny here loves it here, but now he's in pain. I can't wait 6 months to bring him in. So what's your availability? Make sure we can get some of these kids in as soon as possible in a reasonable time. And then it's very important, but it's not what you're measured by right off the bat, is your ability. Are you a good and sound provider? Do you offer great care? Is your work quality and ethically driven? It's something that you're not going to get measured off, right off the bat, because people are more concerned about how you make them feel, and rightfully so. But at some point, your ability will catch up to you. So I always say that don't take shortcuts in life. You know, you got two roads, the harder one or the easier one. Take the harder one because it's gonna the outcome is better. You know, it's just going to teach you a lot about life, and you're going to be able to do things the right way. Once you start taking shortcuts, it's really hard to change as you get older. And so, you know, your ability can catch up to you, and the ethics and the integrity of everything that you do. Let's dive into some cases. I know this is what you guys are waiting for with all the presentations, and you guys had a pretty all-star lineup. I was looking through all the different presenters that you guys have had, and you know, a couple of them. So hopefully, you know, some of these cases resonate with you guys. I wanted to be different. So what I do is I love dentistry. Like I said, I love doing fillings. I call the bread and butter of dentistry, but I want to share some cases with you that you may not think about when you think of dentistry, especially pediatric dentistry. So here's my first case. And this kid's name is actually Michael. He's an 8-year-old healthy male who presented with his dad for a routine dental checkup. And so I saw him the first time, and his chief complaint was just here for his routine cleaning. There's not any major health concerns that his dad was, you know, worried about. He was healthy, no medications, no known drug allergies. He was ASA classification 1. And his dental history was, hey, he was a patient of record, was seen by a different provider before seeing me, and he had dental work done by them. His radiographs were up to date. His extraoral exam was within normal limits. His intraoral exam, he had a mixed dentition, meaning he had a combination of baby teeth and adult teeth. He had soft tissue, was great. M1B1 stands for Malapati and Brodsky. So it's an airway assessment in terms of, you know, your tonsillar pillars and your uvula and how much of that you can see. So he had a pretty good airway is what I'm trying to say there. His midline was on, so when he bites down, he had symmetry between his, you know, between his teeth, and he had a 40% overbite with a 2-millimeter overjet. We all had, and people hear overbite, like you want to have an overbite. Overbite is your top teeth covering your bottom. So that's the way the normal dentition works. And you bite down, you'll notice that your top teeth cover your bottom teeth. How much, the percentage can be different. You can have a very deep bite, which means your upper teeth cover your bottom teeth at 100%. You could have an open bite, which is a lot of kids who are thumb suckers or pull-out pacifier habits. When they bite down, their teeth are like that. They don't touch. So they have an open bite. Or you can have something what Michael had, which is 40%. So when he bites down, 40% of his upper teeth are covering his bottom teeth. So he's within normal limits. Overjet is how much is that distance? If these are my top teeth, these are my bottom teeth, I'm looking at a side angle. What's the distance from the tip of here, the tip of the top tooth to the tip of the bottom tooth? An average is like 1 to 2 millimeters. So he's within normal limits of everything there. Why do I bring this up here? Because this was one of the cases that really, really shaped the way I practiced. Michael was on the verge of committing suicide. And the reason was, if you notice him sticking out his tongue there, he's not able to really, it's a very awkward tongue movement. He's not able to really protrude his tongue all the way out. He seems very uncomfortable. Michael had a tongue tie, and he had a speech impediment, which as I was delving into this a little bit more and doing a comprehensive exam, you know, talked to Dad. And Dad was like, we can't understand a thing that he says. And I told Dad, like, you know, what's going on? He mentioned how they had dinner at home. They keep having to ask Michael, wait, what'd you say? What? And he got to a point where he got so frustrated. He's like, I hate you guys. I want to die, is what he said at the age of 8. Think about that. Looked into that. I told Dad, I think we need to do something here that I think can possibly help, you know, with his speech impediment. Hopefully over time, you know, it helps the ability with some exercises, because your tongue is the strongest muscle in the body. His tongue has been conditioned to respond a certain way and move a certain way for the past 8 years of his life. So let's kind of give him more range of motion with that tongue. And I think this is something I think over time can really help Michael. Well, for some reason my video is not working, but we had him on laughing gas. He was a great kid. Just got him on a little bit of laughing gas. I kind of protruded his tongue back, and get this right of that. This is what his tongue tie looked like before. You can see it on the left there. So he had this little tissue, and it was actually, you can see his 2 little adult teeth that have like little mountains on them. Those are called mamelons, and they're developmental grooves that every tooth has. You just may not have them anymore, because as you eat and chew and grind, they flatten out. But because Michael's 8, these came in relatively, you know, not too long ago for him, he still has them. But right behind his 2 front teeth, that tissue went all the way down and attached down there. And that was the reason why he was not able to protrude his tongue all the way. So what I ended up doing was taking a laser and removing that tissue. That's kind of the after picture there. There's just some couple of the cases I think they do a better job setting up. This slide, you really can't see how that attaches. But here's another patient you can see on the top left. You see how that kind of looks like Spider-Man shooting out his web, and it gets stuck right back behind those front teeth. There's another one right below that looks very similar. You can kind of see the tissue kind of behind the front teeth of the child that has braces. And right below that, you can kind of see how that child had his tongue out. And then after the revision, look at that extension. It's almost double the length of the tongue that you're getting out of there. So at home right now, if you're listening, if you close your mouth and swallow, where does your tongue end up when you swallow? I know you guys can't join in because it's not it's virtual, but it's at the roof of your mouth should be where your tongue resides. It should be the same case when you're sleeping. When you close your eyes and you're sleeping at night and you're in a nice parasympathetic drive, we say tongue up, lips closed, healthy breathing through the nose. There's a lot of good benefits from nasal breathing, nitric oxide being one of the biggest ones, and kind of helping to vasodilate things while you're sleeping. But from an oral care standpoint, you don't want to have a tongue tied, because if you're tongue tied and you can't have your tongue on the roof of your mouth, guess what? Guess how you're sleeping? Open mouth. And when you sleep open mouth, not only is it inviting for cavities because now you have a drier environment, but what happens over time is as you're growing, and we all know growth hormone gets secreted mainly at nighttime when you grow. When you're sleeping, because that's how you grow. Well, if you're sleeping with your mouth open, you're going to get more of this dolichocephalic facial profile, which means a very elongated facial profile. And so a lot of times these kids will grow and have a longer facial profile. And that's because the tongue doesn't have the ability to be parked at the top of the mouth. Now, how do we break this down? Because there's a lot of information here. You can see a picture of an infant that had it on the top lip. So the most common, like I said, a lot of times is the lower lip. You can have it on the top lip, especially with babies. We're having a hard time latching on, whether it's to the breast, and a mom wants to experience a very simple and smooth breastfeeding journey, which is the way it should be, or they're having a hard time on the bottle, whether it's aerophagia, which is a lot of times is the word that I will, as parents, is your child taking a lot of air with their milk? And that's called aerophagia. Well, how does that happen? Well, they don't get a good seal around the nipple of the bottle. So these kids get a false sense of satiety, because when you take air into your belly gets this false sense of being full, because the air kind of distends the belly. So like these kids might cluster feed. They get hungry every 15, 20 minutes on the hour or every 2 hours. And so if you're a parent, you're exhausted. You're waking up at maybe midnight, then 2 o'clock, and 2:30, and then 3:15. So we want to take that away. This breastfeeding journey should be very, very pain-free. It should be very rewarding for moms, and also for dads who are helping and assisting. So not all ties need to be released. But with that being said, for me, everything's functional. So they have to meet my functional criteria. And you can't diagnose these tongue ties by pictures alone. These are pictures that I've diagnosed in real life on these patients. But if you're an infant, the biggest thing as an infant that can get impeded is your ability to take in breast milk. So what I'm asking moms at an early age is, hey, are you having mastitis, mom? Do your nipples hurt? Is it the top or the bottom of your breast? Top usually can indicate an upper one. If it's more the lower part, it's the lower, just the anatomy of how the baby's mouth is on the breast. A lot of times they might have cracked or sore nipples, be bleeding, bleeding nipples. The mom could just be in a lot of discomfort and a lot of pain. And so those are the main signs that I'll see there. In terms of what I'm asking in terms of with the child, are they fussy, aerophagia? Are they gassy? Are they burping a lot? Are they dribbling and drooling down the sides of their mouth? That's another big key. And then what I'll see is sometimes if I see a kid that has a little bubble on their inner lip, that's a pressure point. So if I ask all of you guys right now, take a finger, thumb, finger, push down on it real, real hard. Hold it for 5 seconds, and now let go. What color did that turn? Should be white, because it's blanching, right? You're blanching your soft tissue. If you notice these tongue ties, and if I look at that picture right on the top left again, it is going on the top left. If you look at the middle of that string, what color is that? It's white. So these tissues are constantly under pressure, and they're constantly being blanched. So imagine walking around with your finger being squeezed all day. You're not going to be able to get 4-inch of motion, the ability to up with that finger that you would want. That's kind of what's happening with these upper ties or the lower tongue tie. And so that's at the infant stage, where we're trying to nip it in the bud if we can. If you go through that, let's say your mom, you did not breastfeed, and you did the bottle feeding experience and formula throughout there, you're not going to understand and maybe not even catch on what happened, because a lot of this is proprioception. The mom can feel it when it comes to breastfeeding. Now the child is 7, 8 years old. Well, phonation and dictation, the way we speak, starts to get mastered around that age. So at that point in time, same thing. I'll ask them, how are they sleeping? I'll ask parents a couple of questions when kids are like, toddlers. If I see someone who's like 3 or 4 and it's really severe and I assess it, then I'll nip it in the bud early. But let's say I don't see them until 7, 8, 9. Now I'm trying to access and get an assessment of their speech. So I'll have them say words that start with PH. Thunder, 31, 32, 33. If you try to say those right now at home as well, say 30, 31, 32. You'll notice that your tongue makes contact with the bottom of the upper teeth. Th. That's how the th sound is created. If you have a severe tongue tie, you're not able to say 31 with thunder. You're saying 30, 31, 32, 33. You have a substitution. And it's an F sound that gets replaced by it. I'll also ask for other speech sounds, such as the R's, like Roger Rabbit, raindrop. And I'll have them say like funny things. And you'll notice these kids, they'll have a hard time sometimes with their R's. They'll say Roger Rabbit, Waindwop. And so you almost get this Elmer Fudge from Looney Tunes. You know what I'm referring to. You kind of get that kind of substitution in their voice and their sound pattern. And so those are some red flags, because at that age, they should be mastering phonation and dictation pretty well. In conjunction with that, I'll ask them, hey, how are they sleeping, mom and dad? I make them do a very at-home, easy sleep study. I just want the parents to pop in every night, a couple of times if they can, and just monitor and see how their child is sleeping. How are they breathing? Like I said, tongue up, lips closed. I want them to be healthy breathing through that nose. If they're or flags as well. And the last thing at that age, because now they're more aware, and these kids can follow directions, I'll have them take their tongue and go all the way around. And you can do this at home as well. This is the kind of cool stuff about this thing, is you can kind of test yourself. You should be able to take your tongue and really touch all the edges and feel all the nooks and crannies of your teeth. Some kids, if I put my finger here and they can't curl their tongue up all the way. And when you're eating and snacking throughout the day, the last thing you want to do is take your finger and pick food. That's why you have your tongue. It helps with cleansing. It helps take the saliva and all the immunoglobulins and, good things. And obviously the bad bacteria in the mouth, but all the good bacteria, kind of the, I was saying, so immunoglobulins rather, and take the components of saliva and helping you cleanse your mouth, keep that oral environment nice and healthy. And so if they can't do that, that's another red flag. Those are just kind of the 3 things I look at. And then last but not least, they're older and adolescents going to braces, maybe if they're 11, 12. Sometimes what you'll notice with braces, there's 2 teeth on the bottom will start to flare in, especially if a very strong tie. And so you can have the teeth with orthodontics go into a nice, beautiful state and kind of flare out. If you do the tongue tie, you'll notice that the tongue will automatically help drift those teeth into the right spot before orthodontics. But let's say you've had orthodontics and now your teeth have come to the right spot with the conjunction with the help of orthodontics. You get your retainer that you're wearing and you lose your retainer. Your dog ate it. Now you don't have a retainer. Guess what's going to happen? All that hard work is going to pull back in because your teeth want to go back to their natural position. And when you have a force that large, it's pulling back on the teeth, it's going to take it back to that natural position. So by doing these in kids who are a little bit older, you also help relapse. It can help significant by keeping the teeth in a better position aesthetically. Last but not least, you can also kind of unfortunately be on a CPAP machine long term. So what are the long-term ramifications if this is not treated? From a functional standpoint, you can just kind of develop sleep disorder breathing. A lot of grinding, a lot of adults will grind. It's called bruxism, and they'll grind their teeth. A lot of kids will do that too. It's all stress related. Kids' stress is very different than adult stress. Obviously, with what kids are worried about. I mean, I didn't get my Oreo cookie at lunch, and or little Johnny had I want to have. They stress out about different things. When you're in your shoes, you guys are stressing about your midterm exams. You guys are stressing about different things. And so when you also have a limited tongue mobility, well, you have this 6-foot tiger, your tongue, in a 3-foot cage, which is your mouth. And that can also complicate certain issues. And so as you get older and certain things are not taken care of, it can lead to, like I said, biggest things like sleep disorder, breathing issues. So I think we kind of really hammer that home. That's kind of like I said, I'm sorry for spending a lot of time on that, but that has been one of the most revolutionary, the most life-changing procedures I do, hands down. And the impact that it's had on many families, from 3-year-old babies that I've seen to 16-year-old, adults, has been profound. And so I want to start off with that case. The next one is like an orthodontic exposure. So I have a CO2 machine, which is awesome, that allows me to do this. But we have a 13-year-old healthy female here. She's got tooth number 11, which is the upper left canine, adult canine that's impacted. And kind of we need to kind of help it with extrusion. It's kind of extruded a little bit. So you can kind of see if you, on that first picture, I lift that mirror up. That tooth is kind of extruded the gums, and it hasn't really dropped down in line with the other teeth. So what we want to do here is that second picture, I just made a little, if you follow the arrows, I cut a little kind of a window so I can expose that tooth. Put a little bracket on there that the orthodontist, sometimes the orthodontist will do this. Sometimes the pediatric dentist can do this as well. And then what happens in the next step, this is now in conjunction with the orthodontist. That picture on the bottom right, they ended up putting on almost like an elastic band, a clear elastic band from that tooth to the rest of the arch. And then if you follow the picture, second last photo, you can kind of see how that tooth nicely dropped into position. And then that very last photo, it's right there. Now we've got a little bit of a gingival defect on that area with the gums there. And so that has actually healed over time just from good home care. Sometimes you'll get that, and you might need to see another specialist that does a little bit of a grafting procedure to help the tissue right there. The ideal position for any tooth to come in is straight down. But sometimes you will get these cases where the tooth is just coming out a little more angled. And if you have to be able to get the tooth in the arch and help their aesthetics, this is one cool case where we use the laser to do that. So 2 different uses of the laser. The first one being frenectomy. This last one that you noticed was with the orthodontics. I also do gingivectomy. So if someone has very kind of thick gums, we'll do that. If someone has a tooth in the back that has a cavity and the gums are flapping over, we'll do an operculotomy, which is a perculectomy, where you remove gum at the back of the tooth that's covering part of the tooth. So the lasers come in handy for a lot of exposure cases. The third case here is called a complete oral rehabilitation or a complete dental oral rehabilitation. So in this case, a 4-year-old, super healthy. She has a very high caries rate. She had back teeth that needed work. I highlighted the front teeth on this picture here. But the reason we went doing the treatment with her fully asleep was, as cute as she was, the cooperation wasn't there. So she was unable to take x-rays or sit in the dental chair. And so the last thing you want to do is, go in blind doing dental work. So doing a complete oral rehabilitation under IV sedation in the office for me allows me to take x-rays on these kids once they're asleep, establish a proper diagnosis, and take care of any and all treatment that needs to be done that day. So what I highlighted here, you can see on her picture on the left, she's got these big yellow cavities actually on the front of the teeth. They actually wrapped around to the back, and so we put these nice little white crowns on them. This was probably about 2.5 years ago, and so since then I have changed the crowns that I use. You can see, these were kind of the only options that I had back in the day that I was comfortable using. They're nice and white and bright, but they're kind of chiclet looking. And so to kind of fast forward, I just did this case a month ago. If you see the picture on the top right, that's another type of zirconia crown. A lot more, I think, aesthetically pleasing. Maybe not as bright and not as white, kind of to the eye. But that picture on the top right there, we did the front 4 teeth, and you can kind of see the difference between, like I said, this picture where they look, her bite was great. She's pain-free, cavity's gone, all that stuff is great. But now I think with some of the things that are coming out, I think a little bit more aesthetic, and I think I'm a little bit more happy kind of with the way these crowns look compared to the ones I've used in the past. So these are just the other examples of treatment needs. The first 2 pictures on the top left are an example of a white crown and a stainless steel crown. So you can kind of see kind of what I end up in the cavity. I kind of end up drilling the tooth. The one that looks like a little ring within a ring is the white crown, and then the one right behind it is where we did that silver stainless steel crown. You do these because there's not enough tooth structure to do a white filling, and if you do a white filling, it's going to be too big, or you're kind of compromising the integrity of the tooth structure. So you want to give more of a full coverage on that tooth. The case in the middle right there is an example of a spacer. Kind of one of the treatment modalities I referred to at the very, very beginning of this presentation. So some of these kids, like I said, they come in, I couldn't otherwise do this on this child if they were awake, too young, and the behavior's not there. So we have these prefabricated spacers that you kind of try on, you put together. It's like kind of putting Legos together, and you can cement it right then and there. So now I don't have to worry about bringing this child in because I just made them a spacer. So that way things don't shift, and the adult tooth, when it's ready, will come right through that gap, and we just take that spacer right off. Nothing that they can take off at home, but it kind of helps kind of keep things at bay, and that keeps the spacing well maintained. The picture on the bottom left is an example of an adult tooth. You can kind of see it's a little bit shorter, and then right next to it, we kind of built it up. But some people have peg laterals, called peg laterals, because they look like you think of pirates or like a peg. It's exactly kind of what the tooth looks like, a little bit shorter. And so we'll usually have maybe the orthodontist sometimes bring the teeth a little bit closer together, and then the picture, we can see that white tube in her mouth. She's not intubated at all. That just takes away all the spit and saliva. She was completely awake for the procedure, but allows us to take away, keep the area nice and dry, and then put a nice little kind of white resin crown. That material that we use is the same material that you use for filling. We just have preformed crowns that are different sizes, and you can shape and contour the tooth when you're all done. And then last but not least, in the bottom, you can kind of see that yellow spot on the front tooth. That's an area of like hypomineralization or decalcification. Some of you may have like little white spots on your teeth as well. And that's just can happen during almost any stage of dental development. Sometimes you could have been little, had fell, and hit your front tooth, and that caused the adult tooth to come in with a little bit of a hypomineralized or demineralized area. Sometimes it can be just due to the nature of the tooth and its growth phase when it came in. But one of the cool treatments we offer is this. It required no drilling. It's an acid-based system called ICON, ICON, and you pretty much apply it to this area of the tooth, like a high acid base. Kind of do it multiple times, and then the result is you can see how that yellow spot like went away pretty nicely. So it's almost like bleaching the tooth without ever putting a drill on it. And so these are just kind of examples of other things that are treatment that are outside of the scope of just doing drilling and filling the teeth. Cool case I did a month ago here. I love oral surgery, and so this is an oral surgery case where the tooth was fully bony impacted, meaning that was completely in the bone. And I don't know if you can see my pointer, if it works here or not, but that very first picture with kind of the x-ray that you can see, you might see this little tooth that's a little sideways. You see a tooth, almost a gap, and then another tooth, or in that gap, if you look just above the gap, you'll see this little tooth. That's a baby tooth that never came in. And that's very, very unusual. It doesn't really happen that often. And so the options here were, hey, do we send this girl to the oral surgeon, which is a very viable and right option to do? Or if you notice the initial photo, that's the photo that says initial photo pre-op, you can see the third tooth down has a cavity, a large cavity. So this girl had a bunch of other dental work, and extensive dental work that needed to be done. So we did an IV sedation. She was completely asleep. We not only did all the dental work, we were able to get that tooth out. And so what we ended up doing was going in there, I raised a mid-crestal incision. So I took like a very sharp scalpel and kind of made a cut going around. So that the canine tooth, the second tooth that you see there, starting at the very front of it, curving around the tooth, the straight line, the cut, and then going about halfway around that molar that you see there. If you jump now to the bottom left of the screen, it says flap and exposure of the tooth. So we end up raising a flap. Once you do that, you can take the tissue. Here's my incision down the middle, and I just flap everything open. I'm able to retract that buccal and palatal tissue. This is the picture of it, post extraction. Close it up with some sutures. That's kind of what that follicle looked like afterward. Pretty impressive. And I always like to take a post-op radiograph when it comes to these type of things, so I can make sure all the remnant of that tooth is out. So this is kind of cool. Your simple extractions are just kind of taking a tooth out. I just thought this would be a little bit neat because this kind of shows you the different possibilities that are in your wheelhouse as a pediatric dentist. If you had to refer to an oral surgeon, totally fine. I always say do what's best by the patient. A lot of my colleagues love surgery. They're just not comfortable doing the stuff. And that's A-okay. At the end of the day, you don't want to do something that you're not comfortable with and it harms the patient, right? So like the Hippocratic oath, so to speak. So do no harm. And so, but if you're comfortable with it, these are things that you can do. And in this case, for me, it saved her another visit to the oral surgeon who would put her to sleep again. And my goal is that I like to put the kids to sleep as minimally the number of times as possible and try to be as quick as possible. A lot of studies out there showing longer the anesthesia duration and the higher the number of frequency for a child and even adult being under anesthesia, the more that gray matter of the brain getting affected. And so the gray matter, as I've said, super a big part of our cognitive development. And so whatever we can do to help these kids, keep their cognitive ability and keep that gray matter intact, I absolutely want to do. And so that's kind of cool about this case. Another really quick example, this is called a mucocele or a spit bubble. Some of you may have had this, something like you chew on your lip a lot. You might get it, but they're a spit bubble. Just happens sometimes, usually from trauma. So this is excision of that mucocele with a laser. You can see that lip bubble on the bottom left. We kind of took some forceps, lifted it up, I had a cool little laser, and you just kind of take that right out, and that tissue heals very, very, very nicely in about 3 days. These do have a high recurrence rate, so if the child or the adolescent is going back and playing around with them, you could get another one, but the size of that sometimes, the magnitude is different. I like the laser because it cauterizes the tissue. You can see there's no bleeding. And the same thing goes with the frenectomy cases. Because I'm using a soft tissue laser, a CO2 soft tissue laser for that matter, there is cauterization. So this cauterizes the nerve vessels while I'm cutting. So I no longer have to put any stitches in and worry about bleeding, which is remarkable. I learned in residency through, using a scalpel and then stitching things up. And there's just gonna be blood everywhere, and it's not fun. If you have like a 3-year-old, it's just the reality of it is you can't do that. And here, I have the ability to do that without ever have to worry about blood, and the post-op healing is super fantastic. And so those are some of the biggest keys. So wrapping things up here, and I'll open the floor up to questions here. But I love dentistry. Kind of like I said, I think my story is I had leukemia as a child. I had ALL, which is acute lymphoblastic leukemia. I've been in remission since the age of 5, so it's been 30 years for me. I feel super blessed. I feel, a lot of what I do is kind of, I just feel like I'm happy. I'm really, really happy giving back to kids. And that's, for me, the leukemia is probably the biggest blessing that could have ever happened to me. Because as I went back into my chemo unit as I grew older to see my doctor, my follow-ups, I saw a lot of these kids who were hooked up to IV poles, no hair. They were the happiest kids. And the HEMONC unit almost became their safe haven. And as I got older, 14, 15, 16, you grow, you learn, you start seeing things, the world around you shapes you and your views. And I realized, hey, this is remarkable that these kids are some of the happiest people I've met. And I want to give back to kids. And so for me, I knew going to pediatrics wasn't the problem. It was, would it be medicine or dentistry? I'm ambidextrous. I've come to learn, using both hands. I thought, dentistry was great for me in that regard. And then I just like instant gratification. I like the fact that someone comes in not feeling good and they leave feeling great. And that was something that was important for me. And I thought dentistry gave me that ability and offered me that to do. I also think my hour, like I said, from a personal and financial freedom, money is not the end all be all. And I think you'll quickly realize that once you get into the real world, you'll get your first few paychecks for the first few months. And you're like, this is awesome. This is great. All my hard work paid off. And there'll be a point in time you'll be like, the money is getting jaded. It's money. You make $50,000 less at some point in your career, it's not going to matter. Right now, it sounds like a big amount, but over time, as you accumulate wealth and financial freedom, you realize that you want your time back. And I think dentistry is rewarding because I have complete autonomy of my time, and to me, that's huge, especially to start a family with 2 boys and living life on my terms. And so, with that being said, living life on your terms, build your own life resume. Don't worry about. Work hard. You guys are all going to work hard. I know you guys are all that pre-med track. So, I think working hard comes with the territory. Just put your best foot forward. I think the best conversations in life are the ones that are the experiences that you have. Hey, you went to Argentina, you had wine, or you traveled to Nepal and saw Everest. These are conversation starters that can teach you more about life than 4.0 GPA. So work on building your life resume. One day you'll get to a point where no one cares. No one's going to care what school you went to, what your GPA was, how fast you can run a mile. Don't care. How do you make them feel, right? How do you make someone feel? Empathy drives human connection. And so, find your why, find your purpose. Find out what makes you passionate, purposeful, and intentional. And if you can find that out, you'll find your why. And that's the biggest thing. are you doing medicine because your parents want you to do it and they want you to be happy? And it's a real question I ask, because a lot of times people go, I think so. Like, my parents are really pushing for it. Your parents are, all of our parents want to live vicariously through us, but they're not living your life. So don't do something because your parents want to do it. Do it because you want to do it. Otherwise you're doing yourself a disservice. So find something that you're passionate about. At the end of the day, you can create your name. And your parents, I feel like people are gonna love you for what you give to the world. And if you're not passionate and purposeful, intentional about doing something, you're doing yourself a disservice. Forget your parents. Forget the rest of the world. You're not being true to yourself. So find your why. Find out what really, 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 really drives you. If it's not medicine, it's totally fine. And fail forward. I don't know anyone that's ever succeeded without failing. So embrace the failures, embrace the challenges, and realize that there's a silver lining to every single situation. After my first job, I was telling you guys, I joined a practice outside of Philadelphia to get me back to Philly. Well, that practice got raided by the FBI on my 6-month working anniversary due to some, obviously not so legal things that they were doing. I had a lot of resentment and was really, really bitter. And then realized as time went on, like, that was the best thing that ever happened. I learned so much of how I want to practice, how I want to live my life, what I value. And I come to realize that there's a silver line to anything. You fail your midterm, right? You have a midterm coming up, you fail. In the moment, it sounds like it's crazy. You're gonna look back at it 10 years from now and be like, you'll laugh about it, because guess what? You'll realize you got to where you wanted to be, and nothing stops you. Do you have road bumps? Sure, we all do. It makes you stronger. It brings out your character. So, like I said, don't let your highs be too high. Certainly don't let your lows be too low, and just always keep a positive attitude. Be your own superhero. It's my mantra. It's my ALL kind of story. And it's all about empowerment, right? Like, we are our own superheroes. We all have a unique gift to this world. And it doesn't have to be medicine related. If you just you could be a really good orator and you like to talk to people because your voice is comforting to them. That's a talent. Not everybody has that. You can invent something and you're really, you're an outside the box thinker. You can be a really good listener. I think it's one of the most underrated skill sets, is being a really good listener. You're your own superhero. You have a unique skill set that nobody else has. You just got to tap in and find out your why. And then the biggest thing I love is just be grateful and love unconditionally. Being grateful is the number one way to raise dopamine and serotonin levels in your body. Number one way. Better than getting an A on your midterm coming up. Just being grateful for the fact that you wake up every day, you got the opportunity to fulfill your dreams and live out a life, and impact people and those around you. So just have a lot of love for everything and everyone, and I guarantee you, it'll come back full circle. I say thank you. Stay blessed. This is kind of my family, my boys and my wife, and we were the superhero family for Halloween this past year. It's only fitting they made me the villain, of course, but we had said we're all about kind of living life to our full potential, and these guys are the reason. This is my why, outside of dentistry, and they push me to become a better human being every day. And then that bottom picture says on the bottom right, to follow that dream. So dream big, fail in the process of that dream. That's how your dream becomes a reality. So don't be afraid to fail. And I really appreciate your time, effort. I really appreciate you guys being present in the moment. You guys should be doing anything tonight, and the fact, either you're in the present moment watching this, you're going to go back and listen to this. I really, really appreciate and value you for your time that you're putting into this, and hopefully it was meaningful. My contact information, I said, it's at the Superhero Dentist on Instagram. And if you ever need to email me, it's Dr. Deep I Shah, DrDeepIshah @gmail.com. And so I'm here to help you on your journey in whatever way I can. And even if it's not dental related, I have a lot of contacts in different fields, and whatever can help, fuel your passion in life, I'm at your service. So thank you.
Well, I'd first of all like to say this was such a great presentation. Very, I'd say, especially as you're going through the cases, very intuitive, especially for us being mainly undergrads on the call. It really helps just with picking up things. The way that you explained it, it was very thorough. So we really appreciate it. Personally, I learned a lot, and I'm sure many of the people in the audience watching right now could definitely say the same. Just to start off with some questions, like I said, a lot of us are in undergrad at the moment. We do have some pre-meds, we do have some just general pre-health students, some pre-dental students too. But I mean, all of us being on the pre-health path, experiences are important for us, especially before moving on to the next step of professional school. So for you, now having been through years of practice and having completed undergrad already and training, what were the extracurriculars that you took part in that you found most impactful now being at this point in your life?
Yeah, I mean, for me, it was dancing. So believe it or not, like I did a little bit of research, and that's I actually enjoy research. So I think this might I can't see the question, but one of the questions I get frequently asked is like, I research, I do it not, and the question is, do you like to research? If you don't like research, don't do it. I mean, it's not something that you want to be passionate about something, right? I think it all comes down to what drives you. What are you passionate about? I love dancing. I danced like throughout my collegiate years, my 4 years, and then actually in dental school up until like my second year, and I was like, I just can't do this anymore. It's like late nights, burn the midnight oil. I had my dentures and my fire going in between the songs that I was not part in. And it was my turn. I'd literally go up and dance and come back, and I was like, it's like I gotta stop. Like as much as I love it, I just realized I got to focus and put my attention to this. But outside of that, that's all. That's literally all I did. And then I like a passionate and avid dancer, founded a dance team, and was captain, did that, and then I just did a little bit of research. So I would, but I tell people find one or two, maybe three things that you really care about and that you can do for a longer period of time. So when I'm looking at, like I said, I'm part of like the dental committee at Penn for like interviewees and applicants. And I like to see from an application standpoint, I would rather see somebody that is like invested into two things that they've done for 4 years or 5 years, rather than like eight things that they've done for like a year or two. Because then that just shows me commitment and something that they really like care about and they really are really passionate towards about. And so that would kind of be my take is you don't need to do something in the healthcare field. You could go overseas and study abroad and have a phenomenal experience that you can share with. Because at the end of the day, like when you get an interview or you're interviewing somewhere, you know, great, you made it, you got your grades, like you've done well enough to get you to that point. Now it all comes down to empathy, right? And like a kind of like human connection. Can you jive? Are you going to be a good fit for your program that you go to? Can you uphold the conversation? Do you have a personality? Tell me about, like I said, do you have a life resume? Because at the end of the day, like that's what's going to really jive. It's really, I mean, what you did is no different than 999 other people around you. You worked your butt off. You tried to do as best as you could, and you got an interview. And there's something that to be, that's something to be said about that. That's a very, accomplishing feat. But it's like, so what? It's like, what makes you different? And so I say, do something that really is unique and different, and that's true to who you are. Because I think that at the end of the day, that's really what's going to shine.
Absolutely. So I also wanted to ask another question that came in is being so many years in practice or having already been out of the training, do you feel like at this point in time, you still are able to learn about the specialty? Is there more to know about pediatrics, about dentistry in general that you haven't yet covered and you're continuing to learn on the job?
Yeah, always. I think totally say I took my last breath with anything and everything. And when it comes to pediatric itself, like I said, I think one of the cases showed you like a white crown that I did not too long ago, and then like now these new crowns that are coming out. I think being in academia is great because there are a lot of things that that the medical field and the dental field are throwing out. Now, the biggest downside of dentistry, if there is one, is in terms of research. I think we're about 5 years behind, 5 to 7 years behind in terms of advancement with medicine. You'll see all these advancements in medicine, and then dentistry is a little bit slower to catch up to certain things. But with that being said, like there's a lot of neat things, and the field's growing a lot in general. From implants, as I said, pediatrics is just one of like maybe 9 disciplines amongst dentistry. But from implants, different techniques on how to do things. Here's one of the really cool things is we have AI now in dentistry, and so we're using artificial intelligence to help us detect cavities in teeth that otherwise might be hard to see. So, at the end of the day, the autonomy lies with the dentist, and they can, whether they can say, hey, that cavity is true or not, you can override the AI. But transparency is so key. So, what the AI technology, one of the things it allows us to do is say, okay, mom, little Johnny here had a cavity that was 20% into the enamel. The enamel is the hardest part of your body, by the way. You got the tongue, which is the strongest muscle, and the enamel, which is the hardest part of the body. It's two cool facts just throw out there. But the enamel, once the cavity progresses halfway through the enamel, now it becomes almost like softer and softer until it gets the nerve. So you really want to preserve that enamel. And these AI properties these programs will tell you, so mom, little Johnny's cavity was like 25% into the enamel. And now 6 months later, we progressed about 74%. And it's pretty awesome. And so now you can put evidence and data in front of the parent and help them, like, hey, listen, I know we were watching that tooth and we didn't want to drill it because it wasn't necessary at the time, but I think we need to intervene now. Otherwise, this will get worse down the road. And so those things are really neat in terms of what you can do. So I think, like, the needle is definitely moving forward in medicine and dentistry. Is dentistry a little bit slower? Yes, unfortunately, I think it's just the way it is in terms of the funding that's put into it. But there's a lot of cool, technological advancements that are coming, and the next 10 years are considered like the boom years of dentistry. We're really excited to see what else is, going to come out. One of the other things, so those zirconia crowns that you saw, the white crowns on the back, they're very aggressive. And what I mean by that is, if I can quickly just go back to the slide, just highlight something, just so you guys, if you're able to see it, on this top left picture with the mirror, if you can see the mirror, now you kind of see like a little ring around the one tooth. That tooth is quite aggressive in terms of how much tooth structure I need to remove to put a zirconia crown on. They have new material that's actually coming out January of 23. That's going to be just like that silver crown, which is very minimal preparation. The goal is to take away as much tooth structure as you possibly can. And these new white crowns that are coming for the back are going to emulate the way those stainless steel crowns are done, which is very minimally invasive, and they're going to be white. So these are some cool things that are coming out. I can't do those zirconia crowns on a 5-year-old that's very active and moving their head, just because how technique sensitive they are. But I will be able to do these posterior white crowns that are minimally invasive in terms of how much preparation on a kid that's a little bit more active, because it'll take me a fraction of that time. So it might take me 5 minutes to do that. It will take me about 30 seconds to do the other one. So these are some cool things that are coming out in dentistry. So sorry for the long-winded answer, but I want to put some tangible things and visualization that you can see to what I'm mentioning.
Our next question is about what made you choose specifically pediatrics over another specialty. You mentioned your own story. Did you ever consider other specialties outside of pediatrics, like orthodontics? There's, I believe, 5 or 6, right, other specialties within the industry?
Yeah, there's 9. I think, yeah, there's a ton. There's radiology, and like oral surgery, periodontics, and prosthodontics. I was really considering oral surgery. I love surgery. Couple things, I think, for me, it didn't have that gunner mentality, which unfortunately can be associated with a lot of oral surgeons. It doesn't mean that they're bad people. They're just like very driven differently. And I just think I love when I did my pediatric rotation in clinic, I really fell in love with kids. And I think it kind of took me back to my experience growing up. And so I just feel like kids are a clean slate. They're very moldable. They're highly impressionable. And you can have a profound impact on their life and shape them at a very early age. And I know that was kind of, with me. And so I kind of wanted, for me, I thought peds was just the right field for me to go back and kind of, it just aligned with my philosophy and kind of what I wanted to do. But I did consider oral surgery. I actually got a lot of awesome oral surgery exposure in residency, which allows me to do like the case number 4 that you saw with that full bony impaction. So I'm very content. I'm very grateful to the mentors I've had and to the residency program that I went to be allowed to do that. So I can say that I do a lot of oral surgery in practice, a little bit of orthodontics, because part of your pediatric program, you have to be familiar with orthodontics. So I'm comfortable doing certain things. I definitely nowhere to the expertise and the comfortability of a orthodontist. But I would say good enough where I can diagnose certain things and refer out when need be. But yeah, great question. But yeah, I just felt like pedo. Like I said, I followed my why and my passion and my purpose and my dharma in life. I think is pediatrics.
You mentioned things like CPAP and bruxism. I actually work at a sleep lab, which is pretty coincidental. So I was wondering, do you refer patients for sleep studies?
Yeah, so I will. I actually had another case that wasn't able. It was a video of a child that was sleeping. I should have had it ready. I would have showed you guys right now. And this child was apneic for like 5 seconds. All of a sudden, 10 seconds. And so when you see that, it's kind of like scary. There's no child should be sleeping that way. That's a red flag. Something's wrong. So yes, I will refer to the PCP and ENT as appropriate, to have them have a sleep test done. And M score and B score that I alluded to earlier is something I do with every kid, the Malapati and Brodsky. The person who asked this question should maybe be familiar with that in terms of assessment. So when I see like an M3 or an M4 and like kissing tonsils, which is like a B4, that automatically for me is like this kid is not getting air. So the way your air work, I mean, the airway works is like consider like if I open up really big, let's just say this is my airway right now when I'm having volume coming in. It should be unimpeded. It's a nice tunnel. Well, if you have tonsils, right now, well, these are solidly tight. Now it's a funnel effect. All this air is going through the mouth and has to squeeze through, and so you get a lot of like snoring. These kids are definitely not going to be mouth breathing because you're not getting as much air through the nares as you are through the mouth. But now you see some obstruction, and so if I catch those type of things, and I notice, hey, our M score and B score is significant in the sense where I can kind of and I'll always follow up with, how's your child sleeping? You know, what's going on? Are they tired throughout the day? Are they very restless at night? Are they constantly turning and tossing? Do they come into your room every night when they wake up? Things of that nature. Do they scream for you at night? Sometimes you get these, stimuli at certain ages. Kids are just going to wake up, with night terrors, and that slowly phases out. But your child has constantly been doing this, waking up, tossing and turning, getting up. Lethargic throughout the daytime. These are questions I ask, and I will absolutely refer out for a sleep study when need be. So yes, the answer to that question is absolutely.
It's interesting to see the crossover. I would not have ever expected that would be the case, but that's very interesting. You mentioned earlier that you did move from practice to practice, and we actually did have another dentist on shadowing who talked about how in dentistry, like in medicine, there's a bit of a stigma with moving from practice to practice, but in dentistry, that's more common. So how was that an easy transition for you in terms of moving from practice to practice? And in terms of like making that decision, what factors would be taken into account?
Yeah, it's always tough. I think it was easy because so my first practice was like I said, Wilkes-Barre, Scranton area, home of the office. And when you come out of residency, like I said, you see, I'm very straight up. I'll answer any question 100% transparent. I saw the money and I was like, wow, I'm getting paid very, very well. And like I said, you go through enough of these and you go through enough practice, you realize, okay, like that gets jaded. If I could go back and like I said, I don't think I regret anything because every situation teaches you something. But if someone was like, hey, like if you could really go back and would you go to Scranton? I'd say, hell no. I wish I would have stayed like in Philadelphia or gone to Atlanta or gone to the city. I didn't have any kids. I would have enjoyed city life a little bit more. It was close enough to home for me, like 2 hours away, where I had a good opportunity to really kind of do things my way. There was no pediatric dentist in the area, and I got to kind of have a lot of autonomy. And the financial factor was at that point a huge motivating factor for me as well. So then culture changed. When culture started changing, I want to be closer to home and be in a better environment. That was tough. I think transitioning offices is always tough because you're accustomed to your office, your team members. They're accustomed to you, like my hygienist, my front desk staff, my assistants. Like we just had rapport. And now you go to a different office. You got to, they have to learn your way. You have to learn their way. And the hardest thing is, I think, just kind of reestablishing yourself, right? Like if you go from one geographic area to another, well, all these patients that you work so hard to earn their trust and build that rapport with, now you just left them, and not like leave them because you're being taken over by another provider, but like you're leaving behind that relationship to form a new one, and that takes time, energy, and effort. So I think like that's the hard part. That's the hardest part. The second part of that question, Michael, can you elaborate? I'm sorry. Was it difficult? Or there's something else about it?
It was about the factors, and I think you already hit on that in terms of like maybe the motives might not be in the right place.
All right, yeah. So this is great. So one thing I learned was culture. Culture is huge. Culture, where you work, culture matters. You want to work for a place like where you're valued, you're appreciated, you're heard, and like the way that people are doing things is very ethical. Dentistry, unfortunately, can be a very unethical profession. There can be a lack of transparency. People could say, "Oh, yeah, you need a crown," and you're like, if you're the lay person, you'll just take someone's word for it without understanding and doing your own research and really, really questioning things. And so I think having a good cultural fit is the biggest thing. You don't want to have burnout. I worked in an office. My very first day of my office, my second job, the one that got raided by the FBI. My very first day, I saw 97 patients. 97. I was exhausted. Can I handle that volume? Yes. Do I want to be able to handle that volume day in and day out? No. I mean, yes. I mean, like great, I'm the superhero dentist, but I don't want to live like a superhero every single day of my life and flex my muscles and say, yeah, I can do this. And then it affects your mental health and you're exhausted. You're waking up at night. Oh my gosh, did I write the note for that kid? Did I do that treatment? I mean, you go crazy. And so burnout is real in medicine and dentistry. So you want to be at a place that allows you to have a very good work-life balance. And these are things I feel like as a young professional, you don't think about because you've invested so much time and energy into studying that how do you reap the benefits? And the first thing many people think of is financial reward. I just spent 13 years, educating myself. I want to be rewarded for my time. I want a monetary reward. And that's great. I think people should be rewarded for the time and energy. But just remember, if there's three things to a practice, and if this is one of the most helpful tips I've ever gotten, there's three things you can get with any job. One is your scope of practice, and that tells you what you're able to do. So you just went to training, you finished, your pre-med, you got your fellowship, you're done, and you worked so hard to get really good at something, but you go to a practice that limits how you can do things. You're not going to really grow. So your scope of practice is huge. You want to have autonomy to do things the way you want to do them and grow, put your training into use. The second thing is location, right? Do you want to be out somewhere in a rural area or do you want to be a part of the city? Your location, where you want to go matters. And then the third is salary, right? Are you getting compensated well? The least important of those three, in my opinion, are let's put it this way. You want to hit 2 out of the 3 of those, whatever those 2 are for you. However, keep in mind, as your scope of practice gets better and better and better, this third thing, money, salary, follows it. So don't get hung up on the money, because when you get really good at what you do and you find a niche for yourself, the money comes with it because you're already such a unique provider that it's going to come along with it. The experience drives things. So my advice to you guys is you look for your jobs, 3, 4, 5, 6, years down the road, look for something that gives you the opportunity to grow, that allows you to practice the way you want to practice, and that has a really good work-life balance. And when that time comes, feel free to reach out to me and let me know about your situation. I'd be more than happy to help you and give you some tips at that point.
You mentioned doing some operations, is that correct? As a pediatric dentist?
Yes.
So is it possible that some pediatric dentists could just choose consultation if they would only like to cover that part, or is that not necessarily a typical way of practice?
It's tough. It's not a really typical way of practice. And the reason for that is if you do a consultation and you diagnose something, and now someone else is going to be doing that work, they may not necessarily agree with the way what you've diagnosed. And so dentistry is a model where a lot of the times the continuity of care is very important. We try to make sure the providers that I mentor, a lot of them want to have continuity of care. And so what that is the ability to, hey, if I saw and consulted my patient and I diagnosed things, I would love the ability to see that patient again. A couple of reasons. I diagnosed it, and so I'm familiar with the situation. B, I've worked hard and gained their rapport and trust. And C, my method, and I think kind of like my philosophy behind it is true, and it's something that jives, and it's a win-win situation. Sometimes if you diagnose something and now another provider sees that patient, let's say you diagnosed 2 cavities, and the other provider comes, they see the x-ray, they're like, oh, mom, actually, your child has 6 cavities. And it happens before because everyone's a little bit different. Some people are a little more aggressive in their philosophy, some people are not as aggressive. And then right then and there sometimes lies the discrepancy. Now the parent's like, well, we were just told 2, and now you're telling me 6. And wait, what's going on? And then trust, right? It's that T word, trust kind of gets derailed. And so bottom line is the way a lot of the providers and the residents are coming out now, and even for me, back in 2015, I wanted the ability to treat, diagnose, and then treat. Now, sometimes I'll see another provider's case, and sometimes I'll explain to them, hey, listen, I can see where this provider came from, and with all due respect, I understand that, but hey, this is what I might do differently. Like, they want to do a crown, I think we might be able to get away with a small filling here. Or hey, they want to do a filling, well, mom, you kind of see how the x-ray of this tooth is compromised, I probably would consider doing a crown. So I think the art of this comes down to how you communicate and verbalize your thoughts to your parents or to your provider or to your patients. And that's something I feel is very underrated. Medical school, dental school, ophthalmology school, pharmacy school does not teach you how to speak to patients. And if you can become a very good orator and a very good dictator in terms of how you're able to phonate, dictate, and have command of how you're saying things. It's very powerful. Now, the goal here, you're not trying to sell something. So you're not trying to be a business person, but you are trying to, in a way, quote unquote, sell something for the best interest of that patient. And so the way you communicate that is a big key component of that.
Yes, absolutely. Bedside manner. I mean, it's something that's emphasized, but like you said, it's not covered well enough for what it's worth.
Yeah.
Another question, and this connects back to being in a practice. What are your thoughts on how many providers there are with, larger and smaller groups? What are pros and cons you see of each?
Yeah, it's actually a really good question. A lot of people come out nowadays want to have like a multi provider practice just so they can bounce ideas off of each other and be able to have that rapport. Pros of that, you have more people. If you have 3 people in an office, 3 doctors working, you have that collaboration. You have someone easily that you can, reach out to and be like, hey, how do I do this? What are your thoughts on this? What would you do? And the collaborative effort on that. And so I think that's one of the biggest pros is that you don't feel like you're in it alone. When I joined my first practice out of residency, I was the only provider in Scranton. And I had my phone. I'd be able to text my co-residents and be like, hey, I saw this case. What are your thoughts? But the pro about being by yourself is I think you really have to have your thinking cap on. I think that moment comes to you that, all right, this is me, myself, and I, trying to do the best I can. And as long as I put my best foot forward, I will absolutely make mistakes. I might fail at a diagnosis. That's okay. It's part of the learning process. But I think it helps you grow up a little bit quicker, if that makes sense. The pressure's on, so to speak. But I think the pro about that is you become a little bit more confident. You realize that, hey, I'm going to stick to my guns. I'm going to make this choice. It's my best judgment. And if it doesn't turn out the right way, that's okay. I'm going to learn from it. And so your learning curve, I think, is actually a little bit bigger when you're by yourself, just because everything falls on you, and you're able to see your own work and be critical of your own work. So there's pros and cons to both. It's a good question.
You mentioned earlier that you were considering building up your own practice. How long would it take for a single provider to get in the swing of things with making their own practice? What does that look long term?
Yeah, another good question here. So it's tough. You want consistency, and so the reason I didn't open my own practice was I don't think I've been fully invested into working. I don't think you're ever fully business savvy from medical school or dental school or these other professional healthcare schools. But I realized that the reason if I opened my own practice was for residual income. I think there's so many different ways to go about creating and generating wealth. It's not by owning your practice. In dentistry, unfortunately, the stigma used to be, a successful dentist is someone who has their own practice, and I think that definition of success has long gone out the window. I think you should only open your practice if you're driven. And that's, it's like your kid. It's going to be your most valuable kid, unfortunately, because this kid actually brings you money and can affect the rest of your kids at home if you don't bring in money, unfortunately. And and if you're not invested in it, your business will fail and you're losing, $500,000 to $1 million. And so for me, I realized I just wasn't passionate about, opening my own practice and dedicating all that time into it. But that being said, I really envy it. I'm really proud of people. I really respect people that own their own practice, but there's a lot of time and energy and work that goes into that. You start off by maybe working 1 day a week, and then build your way to 2, 3, 4. Pediatrics, the other cool reason, it's usually a 4-day, 4.5-day work week in dentistry with kids. But there are dentists out there that'll work their way to 5, 6, 6 days a week. When you're starting off, you're on call every day because you're trying to build up your clientele. You're trying to build up your volume and the patients, and you're trying to provide that 5-star experience. So if someone calls you on a Sunday and it's the Super Bowl, guess what? You're going to go in the clinic because at the end of the day, that's what's driving your growth right now. And that's what's going to, that experience that you going in is going to maybe a word of mouth, and that patient tells somebody else, hey, this doctor's great. They squeeze me in. And so you're going to sacrifice a lot more. But that's kind of how it looks when you open your own practice. There's a lot of things to overlook. There's overhead is a big word. It's kind of like you're looking at EBITDA and earnings before interest and tax and depreciation and all these business terminologies out there. That once again, I think healthcare schools do a terrible job in terms of preparing you for the real world. And let's face it, the real world does not work on healthcare. The real world runs off of business. it's all like money and like decision making, and the business aspect of things drives everything. You work for an office, you're not working for free. You work for a hospital. That hospital is making money. So business dictates everything. And so my message is like be familiar with the business side of things and how things work. And I think you'll become better at understanding whether opening a practice is right for you. There's a lot of different factors. It's a great question, but there's a lot of different factors that go into opening your own practice and going. But usually it's baby steps. You got to build volume, and you can't just kind of come out like, all right, I'm open 5 days a week. You're not going to have the volume to do it. And so, and on top of that, if you're open a new place, you've just invested maybe $500,000, $750,000, maybe $1 million into that. And so the return on that, you're looking as a full-fledged operation, to answer, I think, your second part of the question, whoever asked that, maybe in dentistry about like 10 years, 10 to 15 years for you to break even, So think about that. That means for the next 10 years to 15 years of your life, you need to commit yourself 100% to growing so you can break even. After you break even, then it's cool, because then, okay, now you have this wealth, and like now you're in the positive. But then at some point, you come out, so it might take you, depending on your age, 35, 40 years old to get to that point. And then are you going to have multiple offices? Do you just want one office? Obviously, the more you have, the more generational wealth that you can accumulate. Also comes with more struggles. Your team members might call out sick. You might be short-staffed. So there's a lot of different factors that play into this. It's cool. It's like a very different. It's going to just require a little bit of a different acumen. You're wearing your medical cap, but you're also wearing this business owner cap at the same time.
Yeah, they're definitely. I mean, that's a lot of commitment there, and you illustrated it very well. I also wanted to ask about. We mentioned bedside manner. Not something that's really taught really much or emphasized as much as it's worth in professional school. And you mentioned dexterity earlier. That's something that you need to fine tune, especially being in a specialty that includes operation. So was that something that was a learning curve for you as you went through training? Was it something that you already had and you were good with? And when does that usually take place in terms of fine tuning it? Is it more so in dental school versus residency?
I think no, the dexterity doesn't come to you automatically. I think holding. I mean, we're looking at millimeters, right? When it comes to dentistry, you're drilling things that are millimeter, 2 millimeters, and so it's a very, very finesse, depth of things that you're doing. So that's an acquired and learned skill. In dental school, you do a lot of it, a lot of trials and errors, and they teach you how to, the measurements and how to work with things. A lot of these dental schools now have a sim lab. So you can go in and work on plastic teeth, and it's a really, really cool experience before you get into your clinical years, and then you're gonna refine this as you get throughout time. And I think to really master something, I think what they say, there's a book out there that says 10,000 hours. No matter what you're doing, it takes about 10,000 hours to get really good at mastering your craft. And so it takes investment, time, and energy. Once you're coming out of dental school, I don't think dental school, you're not going to be finessed enough in terms of your motor skills from dental school alone, sometimes not even residency alone. It's the hours that you're doing, in that private practice setting, and the years after that are really going to kind of culminate and shape the way you're practicing. You're going to get quicker, you can get faster, you're doing things that are repetitive. And in dentistry, it's kind of like, if you're drilling a tooth, you're kind of drilling the same basic things. There's probably maybe a handful of things that you're doing over and over and over again. And so your muscle memory gets better. Your gauge of depth perception gets a lot better. And so these are things that absolutely, I would say, just take time in terms of you getting really comfortable, confident, and quick with it.
And maybe we can wrap up with one more question. So being in pediatric dentistry, I'm sure, and you mentioned this at the beginning, dental hygiene, and especially with them starting out at the beginning stages of their life, it's that much more important. How do you make it into something that they'll actually apply? A lot of times they might be, I'm sure they'll some patients do miss out on that. How do you make it a system where they can be held accountable, or they have more motivation to go on and actually follow?
Love that question. But I think this goes into the part of where I practice, I preach this philosophy called connection over correction. All right, so connection over correction. So this can be applied to anything. I use it with my kids at home when they throw a tantrum. My little guy spills milk on the floor. I'm not going to say, what did you do that for? That's not going to do anything. That's going to go right over, his cortex, his frontal cortex. He's not going to be able to rationalize stuff. Same thing goes to their patients. I think in medicine, dentistry, healthcare, sometimes we're so quick to give our input as medical professionals that we have a hard time of connecting before we correct. So I think it's important to correct and have them, okay, let's implement these behaviors. But how do we connect with them first, right? So that's his first step. So with my kids that I'll see in a parent, and let's say I have a kid that comes in who's 4 years old with cavities. And I'll be like, oh, like, I build that rapport, have fun. I'm in my superhero attire, we're joking around. And I'll ask mom, like, how are you guys doing? Like, tell me a little bit about, like, Miss Macy here. Like, what did you like to eat in the morning? What's your favorite breakfast food? And I'll ask Macy, like, what's the best thing you love to eat? Like, what's your favorite food? If I can give you something right now, what would it be? And that gives me a good idea in terms of like what she likes to snack on. And I'll ask mom, like, what's her, what are her go-to meals? And I really want them to understand that I'm listening. I'm actively listening to them. I'm taking into consideration their lifestyle, genuinely considering it. And then I'm like, okay, mom, all right, cool. Like, I mean, like, yeah, those are great. Those sound like very delicious things. And then once I ease them into like, all right, mom, let's do this. I do think, what we have here is a little bit of a higher sugar content. So let's take baby steps. I'm big on baby steps. You can't just it's like me telling somebody right now, like, I want to exercise. Great. Go and run a marathon. You're not going to do it. You got to start off by running half a mile and a mile and go there. I think oral home care is no different. So I'll tell parents, but the one thing I'll tell them is just do me a favor. Just brush Macy's teeth every night before she goes to bed. Nighttime brushing, by the way, is the most important time brushing. Because if you have any food remnants left over, there's a great formula called it's sugar plus bacteria equals acid. And that's exactly what's happening at our night, whether it's carbs, whether it's, anything that's sugary that we ate or drank, plus the bacteria that's in our mouth will create acid in a dry environment, especially as parasympathetic tone takes over at night. So you want to brush at night. I'll tell parents that, are they brushing at night, and find out. They are, great. Once you brush at night, you should have nothing to eat or drink except water. If you do eat or drink something else outside of that, just brush again. And so that's the most important thing. But if you really take a look at brushing, right? You brush, let's say average person brushes twice a day for 2 minutes. That's 4 minutes out of it's like 1,440 minutes in a day. That comes down to less than 0.3% of your day that you're brushing. Does brushing really have an impact on your day when it's less than 1% of the time that you're spending? It's important, especially nighttime, because now you're sleeping. But with that being said, diet is the number one factor when it comes to oral health. So I focus a lot of time on helping them make healthier choices and tweaking small things in their diet. But it comes down to connecting over correcting. My goal is to correct. And my goal is to be a successful healthcare provider, which means what I say, I want them to take home and implement. If I see Macy every 5 months or 6 months, she has a new cavity, I'm failing as a provider. I don't want to keep seeing Macy for doing treatment. I want to keep seeing Macy for a 6-month routine cleaning appointment where her teeth are pristine and beautiful, and the parents are doing a great job from diet, home care, brushing, flossing, using a mouthwash, and all that stuff, because I was able to resonate. And I think that's what a successful healthcare provider does, is that they empower their patients to optimize their health. But in order to do that, you really have to understand their story, empathize with them. Don't shame them. Everyone's going through their own struggle. You have no idea if Macy's mom is a single parent, or just had a divorce, or just lost a family member. And so guess what? Lately, brushing has been hard because, we've had other things on our plate that have taken precedent. That's life. So as much as our egos want to kick in and we want to tell them what to do and how to do it, you've got to really get down to their backbone of their story and then go from there. And I guarantee if you do that, people will be willing to listen to you. And it's just like criticism, right? If someone comes and says oh, you're terrible at what you do, you made a mistake, you're gonna be like, whoa. You get defensive. It's just a natural mechanism. Parents are no different when you kind of point out things at them. But if you go with an approach and say, hey, listen, you're doing everything to the best of your ability. I get it. Oh, wow, that must be tough. Hey, by the way, let's try and do this. I know it's tough, but hey, can we try to implement this? Let me know how it goes. And guess what? Your words will not fall on deaf ears.
Yeah.
It's a great question. It's a really good question.
Yeah, that was a great way to end off today's session. It really kind of just recaps exactly the pediatric component of dentistry, which is really what this session was all about. And I have to thank you, Dr. Shah, for taking some time to get this presentation together, for your thoughtful answers. It is so greatly appreciated. Like I said, I think many of the students here I would say the same. Let's see some thank yous in the chat for Dr. Shah. I mean, this was such a great session. We really appreciate it. I do have some last reminders though, before everyone hops off for the quiz. So our quiz is now published on the site. It's under our virtual shadowing page. You'll see, we actually had a Friday session last week. So you'll see a Friday session, or no, sorry, I got that mixed up. Just to clarify, you'll see Dr. Shah's session on the left-hand side, and then you'll see another session from last week on the right-hand side. That might be mixed, but you will see it as you go down the page just a bit. There's 2 buttons for our quizzes, and go to the one with Dr. Shah. The due date for this one is going to be next week, Tuesday, December 13th at 11:59 p.m. Central Standard Time. That's available on our website, although we also posted it in the chat, so feel free to access it there. The same quiz, it's just a Google form, 10 questions, and you need 6 or more to pass. And once you do pass, you will receive a certificate. That certificate will be sent to the email address that you list on the quiz. So we would recommend a personal Gmail, Yahoo, etc. account, any personal account, just not a school account, because sometimes it filters out emails. And if you don't happen to find it in either your inbox or spam folders, feel free to shoot us an email and we can help you retrieve it. Our email address is shadowing.h4h@gmail.com. Like I said, feel free to reach out with any questions, both about the quiz or anything else that you have. We do have a few programs outside of shadowing. So if you do have any questions about that, that's also a place you can go to. For our next shadowing session, we'll actually have it tomorrow. Same time, 7 p.m. Central. And it's going to be over anesthesiology. So we're actually going to see Dr. Crow. He is the Associate Program Director at the University of Cincinnati Medical Center for their residency anesthesiology program. And he practices in academia. So we'll get to see what his life is like in academic anesthesiology. And that, again, will be tomorrow, 7 p.m. Central. That will wrap up the sessions that we have for that week, or for this week, I should say. We will continue with a few more, and then we will have a break afterwards for our fall to spring transition. So like I said, everything's posted on Instagram. We do have our listserv. But yeah, Dr. Shah also has his Instagram. Would you mind just mentioning your handle again? What was it again?
Yeah, it's at the Superhero Dentist.
Definitely. So give him a follow. There's a lot of good content I'm sure that he has. Like I said, we do really appreciate your time, and we'll see all of y'all